Welcome to the fourth day of the International Expert Symposium online, Ivoclar Vivadent. I'm Jean-Pierre Attal, and I'm very proud to chair this International Expert Symposium, in which we are exploring the motto, Succeeding Together, Tomorrow's Dentistry. We are about to start now the fourth live sessions. As every day, it is an hour with brief, straight to the point lectures with well-known experts, followed by an interactive panel discussion. It is interactive, so please do not hesitate to enter questions into the chat box. Answers will be given in the panel discussions or as part of the Q&A download document that will be made available after each day. In addition, you will have the chance to listen to deep dive 60 minutes lectures on all topics in on-demand webinars. These will be made available to you on this platform right after the live session. I remind you that most lectures will be in English, some other in French, and all will be available in English, French, and German through subtitles. The panel discussions will be in English. For all sessions, you can earn CE credits. Just you need to answer the little quiz we provide for each session and webinar. In the first 3 days, we had the chance to listen to fascinating lectures and take part to highly interesting discussions on many topics in digital dentistry. If you missed it, just check out the on-demand section of this site, where you will find the sessions on Monday, Tuesday, and Wednesday, as well as 60 minutes in-depth and demand webinars on the last 3 days. Today, it's about anterior aesthetics, patient's need, and clinical realities. The first lecture will be presented by Dr. Roberto Turini from Italy, who is very well known for his great interest in aesthetic dentistry, both in private practice and teaching as part of the well-known Fradiani Education Institution. He will deal with how professional care and bleaching need to be looked at as an integral part of aesthetic restorative treatment. His lecture is entitled Bleaching and Care as Pillars for Success of Aesthetic Restorative Treatment. Dr. Turini, it's up to you now.
Dr. Roberto Turini from Italy. Thank you very much, Professor Jean-Pierre Attal, for the nice words during introduction. Thank you, Ivoclar Vivadent, for the nice invitation. It's a real pleasure for me to be here, to be in the Ivoclar International Expert Symposium, even though in a web modality. The title of my lecture is quite wide and quite huge, because it's bleaching and care as pillars for success of aesthetic restorative rehabilitation and treatments. So it's a very complex title right now, and in this short lecture I want to give you an appetizer about what you are going to see in my full 60-minute lecture. So let's move on to the topic. And it's quite difficult from my point of view to connect 3 different words, because they are really very different each other. Because we can speak about the care word, so the professional care, the bleaching, dental bleaching procedures word, and in this lecture I wanted to show you how to connect them in the third word, that is the word of restorative dentistry, from the direct point of view and the indirect point of view. So according to this, I want to speak about what is my point of view and the point of view of my colleagues with a lot of questions and a lot of answers. Please consider that normally these questions are the same question that we can find from these two different sides, from the side of the dentist and from the side of the patient, as well as the same question are the questions given by our colleagues during our courses, hands-on and conferences, because there are so many doubts about these three possible words like care, bleaching and restorative dentistry, and how to connect them. So how can we connect these three apparently different words with answering to these questions? Because according to the care word, what can we manage with care protection? Can we create a reliable protocol? Can be applied also by dental hygienists, and which product and why we need to use? In order to answer to these questions in my full-length presentation, please remember that normally care can be subdivided in 4 different sections that are hypersensitivity, the plaque control, cavities, and tooth wear that are really very important. And it is also very important to understand and to answer to an important question, that is which molecule and which product is really useful to work in a safe way, fluoride or chlorhexidine. And I will answer also to this important question, because there is a lot of confusion according to this main question. So just as an appetizer of my full length lecture, remember that hypersensitivity is a very complex topic, because it's very important to do a correct diagnosis process as a starting decisional point before doing restorative procedures, prosthetic procedures, and also bleaching procedures. And so take care not only of the visible part, or better, the clinical crown, what is physiologic, but also take care of your pathologic way. That means the area where we can have recession and we can have an hypersensitivity. So together we can play a game right now that is a game with the 3 patients. The first patient is a patient of 51 years old and no spontaneous sensitivity and has no induced sensitivity. It's very important to take care of the age of the patient, because in this case, according to the age of the patient, the risk is very low. But if we change the patient and we go on with our game, we want to check the hypersensitivity before starting anything. In this case, we have a wound dentition, deep recession, no spontaneous sensitivity, we have induced sensitivity, but the patient is younger because he's 37 years old. And in this case, the risk becomes higher and very high. While on the other hand, if we go on with our game and we change patient again, we can take care of the hypersensitivity. And in this particular case, we have brushing recession, no spontaneous sensitivity, no induced sensitivity, but the patient is younger. And in this case, the risk is moderate. So remember that the age plays an important role according to hypersensitivity. As well as the plaque control is very important. We need to have an interesting compliance with our patient before doing any restorative treatment, prosthetic treatment, or a bleaching procedure also, in order to have a high level of hygiene that is strongly recommended. Because also on the other hand, with plaque, we need to evolve to cavities, and the risk of cavities and the control of cavities is very important, even though in prosthetic procedures, because we can take care of our prosthetic procedures, but we also need to take care of the lesion and to check the difference between a white spot, a normal lesion, an active lesion, or a decay that needs to be treated. And the same is very important to do an accurate diagnosis process also for tooth wear, because tooth wear could be presented with a lot of clinical situation and clinical causes. So I will explain in the full lecture what will happen normally during the diagnosis process. As well as the second word that can be connected is the word of dental bleaching procedures. So the questions are, what is dental bleaching? How does it work? Which material and technique can be really useful in order to obtain good aesthetic results, maintainable in the time, during the time? And can I manage all the types of discoloration? So the word of bleaching is very complex, is the part of the aesthetic analysis. Remember that an aesthetic checklist is very important. This is the aesthetic checklist of our group, where we take care not only of the smile line. So if we have a nice smile line, average smile line, or other situation, but we also take care of the smile width. So how many teeth are visible, and so. Secondary, in a second moment, we take care of the smile line also, where we need to connect the color of this discoloration according to the line, to the smile line of our patients. And it's very important also in this case to take care of the diagnosis process of our patient. Like in this case, for example, it is a very difficult case because there are many previous restoration. So direct restoration that need to be managed before, or better, we need to inform the patient very well about what we are going to do, as well as a lot of situations where we have a real challenge for clinician. The challenge is represented by non-vital teeth and how to solve them in order to avoid, if possible, prosthetic solution and prosthetic procedures. And finally, the word of restoration. We will go in depth both for direct side and indirect side in order to answer to this question. Can we combine bleach and direct and indirect procedure? Which material? What about the unbleachable situation? And how can we maintain our restoration? Because the restorative world, according to our connection in my topic, is very complex, very huge, because we can start from this point and finally, after dental bleaching, with simply cool varnish, we can obtain wonderful, amazing results in terms of color. But finally, in a second step, we need to go on in order to correct also the other parameters for aesthetics, that are the dimension of the tooth, the axis, the anatomy, and so we move on with our workshop. We create a silicone index, and we use this silicone index as a layering procedure in order to create a palatal shell. Finally, after our adhesion procedures with curing lamp, so polymerization, and the way of creating the silicone index is very important, as well as the technique of layering in order to obtain good aesthetic results also in the first step when we remove the rubber dam. And finally, the last point is represented by indirect restoration. That means that our mind is about to change. These are two different images. The first one on the left is an image of Mauro Fradiani, that is my teacher and my mentor, that in 1981, when I was only a boy, so I was not licensed to prepare teeth as a dentist, prepared the teeth in that way because the material were completely different. While today, the preparation are all in enamel, no retention, no mechanical retention, no endodontic treatments, so it's very conservative and minimal invasive approach. Also thanks to new modern material, lithium disilicate for sure, and in the last time also with huge zirconia. So in this situation, we will work on these prosthetic treatment plans, also because we can choose these huge materials, like bleaching lithium disilicate materials. So in these specific cases, I have worked with dental bleaching in the lower arch and with veneers in the upper arch, in order to prepare our patient to the treatment plan and to the final aesthetic result. As well as my last case of this short version, that is represented by complex cases where I have planned all the defect to check for this patient. We started with an orthodontic treatment, creating space for an implant, and we inserting the concept of color immediately, earlier in our treatment plan. Because if I bleach the lower arch, the opposite arch, I am able to choose a more pleasant material for the upper arch where I need to do my veneers. And in this very cool way, we can offer our patient a lot of aesthetics and moving to the lab, creating, starting from the wax with the ingot, with the layering and with the lights and taking care of the lines, so the transition lines, and finally arriving to the function and obviously to the aesthetic, taking care of the texture, emergence profile, and all the position and situation of our patient. Minimal invasive procedures, very important for this position, but also for this position with a wide smile. Thank you very much for your attention, and I hope this small lecture was enough crispy and to see you in my full-length 60-minute lecture. Thank you very much.
Thank you very much, Roberto Turini. It was very interesting lecture. Now we are going to switch to French because I have to present my best friend. Gilles Tirlet est probablement le spécialiste en prothèse en France qui a le plus innové. Innovation avec les restaurations postérieures collées il y a 30 ans, ou même les bridges fibrés en targis vectrice à l'époque. D'autres innovations avec le concept du gradient thérapeutique qui est maintenant repris dans toutes les universités. Innovation avec l'érosion-infiltration. Et enfin aujourd'hui, encore innovation avec les bridges collés cantilever, thérapeutique quasiment inconnue en France il y a une dizaine d'années. Et aujourd'hui, Gilles va nous expliquer en détail comment il s'y est intéressé et où est-ce qu'il en est de ses recherches. Gilou, à toi.
Bien, thank you, Jean-Pierre, for this kind word, and I'm very glad to be there by webinar. Unfortunately, consequently of the confinement, but I'm very glad to be there with all of you for this lecture. And I want to thank Ivoclar Vivadent for this amazing event. Thank you so much. Le sujet de ma présentation s'intéressera au bridge collé cantilever dans le secteur antérieur essentiellement, comme alternative en particulier à l'implant unitaire dans les cas d'édentement unitaire antérieur. Alors, comme toutes les jolies histoires, elle démarre ici avec mon ami, mon frère jumeau. Vous avez vu d'ailleurs les liens de ressemblance, qui est Jean-Pierre Attal, qui est donc le président de ce congrès de l'IES. Et en réalité, ce sujet va être borné par la problématique de l'édentement dans le secteur antérieur. Que ce soit dû à des agénésies, en particulier les agénésies de latérales, que ce soit dû à des traumas, et on sait que ces traumas sont très fréquents. Eh bien, en fait, la statistique que je retiens, c'est que pour un patient ou une patiente sur notre fauteuil, en réalité, la statistique, c'est 100% de sa problématique. Problématique sur le plan, bien évidemment, esthétique, problématique sur le plan de la relation sociale, problématique sur le plan fonctionnel. Et donc, dans ces situations, il faut aller vite trouver une solution efficace, fiable, économe d'un point de vue tissulaire et la plus rapide possible. Les bridges collés cantilever émanent finalement d'un transfert de technologie, et Dieu sait si en dentisterie il y a beaucoup de transferts de technologie entre l'architecture, le monde de l'architecture et la dentisterie. Ce sont des applications qui se font depuis le monde de l'architecture en particulier. On doit à Frank Lloyd Wright, dans les années 30, la première construction d'une maison ici en cantilever qu'on a appelée la maison sur la cascade. Ce transfert de technologie, il se fait aussi depuis le monde aéronautique vers la dentisterie. Il y a énormément d'applications depuis le monde aéronautique, et mon patron et mon maître, Michel Degrange, disait si vous n'avez pas confiance dans le collage, s'il vous plaît, soyez cohérents, ne prenez pas l'avion, car effectivement beaucoup de pièces sont assemblées à l'aide donc de l'adhésion par des moyens adhésifs. Les meilleurs exemples de cantilever dans l'architecture, ce sont les plongeoires, ce sont des bâtiments construits complètement en porte-à-faux. Les principes du cantilever sur le plan de la biomécanique, et je reviendrai donc dans le cadre de la conférence d'1 heure que vous pourrez consulter à l'issue du congrès, eh bien, sont très connus de la part des architectes en termes de résistance des matériaux. Tout ceci est très bien élaboré et on peut imaginer, si on arrivait à se redéplacer cet été, ce que je souhaite à beaucoup de gens, compte tenu du contexte, c'est louer un Airbnb avec un escalier en cantilever pour aller dans une chambre en cantilever, ici dans les Rocheuses, et puis se coucher sur un lit en cantilever. On voit à quel point le cantilever est finalement partout. En fait, augmenter le nombre de piliers va diminuer la longévité d'un bridge collé. Avec un seul pilier, les forces de clivage sont réduites au minimum car les contraintes sont absorbées grâce à la mobilité de l'inter et du pilier, et ainsi on va pouvoir prévenir le décollement. Et pour la plupart des praticiens ayant eu une formation classique, l'idée du cantilever est finalement quelque part contre nature, alors même que les premières propositions datent des années 80, en particulier avec cet article Princeps d'Hopkins. Et quand on regarde la littérature, et j'y reviendrai bien sûr beaucoup plus en détail, à la fois in vitro et in vivo dans ma présentation, on se rend compte que le risque d'échec pour des bridges à 2 appuis, donc des bridges collés conventionnels, est quasiment le double que ceux d'un cantilever avec un seul appui. Et ceci est en relation directe avec le degré de liberté proposé par un seul appui par rapport à 2 appuis. Il n'y a pas ces risques de mobilité différentielle que l'on connaît bien et qui sont malheureusement souvent à l'origine de décollements partiels et d'échecs de la restauration. Alors dans le principe du cantilever, les choses sont simples. On va avoir un seul appui. On verra effectivement dans le cadre de la présentation le choix de la dent moyen ancrage. Et donc c'est ce qui différencie d'un bridge à 2 ailettes conventionnelles. Alors c'est en fait une très jolie histoire, Once Upon a Time, qui démarre en 2006, et en particulier grâce à ce monsieur, le professeur Matthias Kern de l'université de Kiel, qui en fait réalise sur un patient un bridge collé en alumina qu'il assemble par collage, et puis quelques temps plus tard, le patient va revenir, très peu de temps après, et Matthias Kern réalise que ce bridge est fracturé. Donc il propose au patient de déposer... Il propose au patient de déposer ce bridge, mais le patient ne souhaite pas, il n'est pas du tout gêné. Donc Matthias Kern va simplement repolir à l'endroit de la fracture, va retirer en fait va simplement polir l'ensemble et va avoir l'idée à partir de cette expérimentation, à partir de cette situation clinique, finalement de travailler directement sur la conception cantilever. Et d'ailleurs, les publications de Matthias Kern montrent un taux de survie qui est absolument incroyable. Ici, sur sa publication de 2005, donc environ 74% pour le groupe à 2 appuis et 93% quasiment pour le groupe en cantilever. Et à partir de là, Jean-Pierre va réaliser ce premier cas, c'est le cas pionnier dans notre équipe avec Loïc. La prothèse avait été réalisée par Lionel Coudray pour remplacer test incisive centrale. Nous avions d'ailleurs même publié, voici un article à ce sujet, donc ça fait 11 ans déjà. Le contrôle ici à 3 mois de Loïc et ici le contrôle à 9 ans et demi. Donc de Loïc, la restauration étant toujours en place. À partir de là, on va bien sûr suivre à la lettre les recommandations de Matthias Kern. Il voit ici le cas Princeps en 2010 avec 18 ans de follow-up. Et comme Matthias Kern republie en 2017, le taux de survie reste extrêmement élevé pour les cantilevers, environ 95,4% à 15 ans pour ces cantilevers. Dans la suite de l'histoire avec Jean-Pierre, il y a le deuxième cas pionnier. Le deuxième cas pionnier, pour moi, il intervient en septembre 2009 pour remplacer une incisive latérale temporaire qui doit être extraite. Et donc, je vais réaliser avec mon prothésiste de l'époque, Serge Tissier, une stratification au niveau des canines, une facette au niveau de la dent numéro 12, et puis après extraction de cette 62, on va réaliser un bridge cantilever ici avec un appui sur la face palatine de la centrale. L'évolution du matériau, au début, m'avait fait choisir en fait l'incéram alumina. C'est-à-dire, je voulais me coller exactement dans le protocole de Matthias Kern, sauf que malheureusement, avec la facette, on n'arrivait pas du tout à harmoniser, en particulier la luminosité, parce que les deux matériaux sont très très différents et ne matchent pas du tout. Et donc, à partir de là, on a décidé avec Serge Tissier de réaliser le premier bridge collé, en tout cas ici en France, en cantilever en disilicate de lithium. J'avais regardé la bibliographie, très peu d'études à l'époque. Il y avait des case reports de Silvas Duarte, et puis il y avait Stéphane Ries qui avait publié avec des taux avec des durées d'observation qui étaient beaucoup plus courtes, mais avec une loi de comportement qui semblait beaucoup se rapprocher en fait des pourcentages donnés par Matthias Kern, mais effectivement avec une durée d'observation qui était beaucoup moins importante que dans l'étude du professeur Kern, mais qui finalement suivait quelque part un petit peu la loi de comportement des bridge cantilever en zircone. Malheureusement, il n'y a pas eu d'autres papiers depuis de cet auteur, et donc on a essayé de le contacter. On est resté un petit peu sur notre faim sur l'utilisation du disilicate, qui présentait en particulier l'IMAX beaucoup d'avantages, une très bonne aptitude au collage, une très bonne qualité d'adaptation compte tenu de son process de réalisation, et puis une esthétique que l'on connaît à ce matériau qui est assez exceptionnelle, et en particulier dans le cas de cette patiente. Les inconvénients, on les connaissait aussi, propriétés mécaniques beaucoup plus faibles que la zircone et un recul faible ici sur l'étude de Stéphane Ries. Donc voici quelques détails de cette réalisation. On verra bien sûr très en profondeur l'ensemble de ces critères donc au niveau et des réglages au niveau de la présentation d'une heure qui sera faite à la suite de ce teasing. Voilà ici la réalisation du cantilever avec Serge Tissier. Et puis on était tout content finalement de réaliser, en fait, de détourner un petit peu l'IMAX sur cette situation clinique avec une première réalisation donc ici en 2009. Voici ici la vue à 2 ans. Et puis ensuite, ici, la vue à 2 ans et 3 mois avec malheureusement un échec assez retentissant dont on a analysé les causes. Il est toujours intéressant d'analyser les causes de ses propres échecs, en particulier première réalisation, pas suffisamment d'expérience de la part du praticien, également du laboratoire de prothèse, une connexion trop faible, une préparation qui ne semblait pas forcément bien adaptée à cette situation, avec un cofacteur d'usure, en particulier de grignotage des ongles, d'onychophagie, qui ont amené finalement à revoir l'ensemble de cette restauration. Et donc la réfection de cette restauration s'est faite ici en 2011. Eh bien, on a refait exactement la même chose. J'ai modifié les formes de préparation et Serge Tissier donc m'a refait un second bridge cantilever. Ici, on va voir le suivi de cette réalisation. Voilà, ici à 4 ans de follow-up en 2015. Ici en 2016, à 5 ans, on a même finalement une intégration biologique qui est quasi naturelle, comme on pourrait le voir avec une dent naturelle. Bon, on n'a pas toujours ces situations-là, mais vous verrez que c'est un des points très très forts au niveau de l'intégration biologique de ces restaurations en cantilever. Et ici, 2019, donc la vue à 8 ans de suivi clinique. Voici ici à 8 ans la vue palatine. Alors en fait cette présentation, on la verra très en détail j'ai pris un petit peu l'exemple de Top Chef, c'est une émission qui est un petit peu dans tous les pays maintenant, comme une recette, comme un livre de recettes de cuisine en fait, où nous verrons tour à tour comment améliorer l'émergence naturelle de l'intermédiaire de bridge avec ce que j'appelle l'ovalisation crestale, c'est-à-dire la préparation crestale pour recevoir l'intermédiaire de bridge. On verra l'importance du schéma occlusal, et ça c'est un élément vraiment capital, le schéma occlusal, en particulier comment on cale l'overjet et l'overbite pour être le plus minimalement invasif au niveau des préparations de la monoélette. Ces formes de préparation, je les ai fait considérablement évoluer ces dernières années, c'est éloigné un petit peu des préparations proposées par le professeur Kern pour aller vraiment vers des préparations très très minimalistes pour recevoir la monoélette en disilicate de lithium. On verra bien sûr le collage en détail avec des vidéos, les traitements de surface, le contrôle occlusal, et on distinguera les contrôles en OIM, le contrôle lors de la propulsion. On verra les spécificités et les réglages spécifiques qu'il faut faire avec beaucoup d'attention sur ces bridges cantilever. Et puis le contrôle biologique, qui est un des éléments forts également, avec le passage du fil ici, qui permet donc d'obtenir en fait une intégration biologique durable et de qualité dans le temps, de fait de la conception même du cantilever. Voilà, 2 publications ici en mars 2015, un chapitre nouveau dans le livre Fusion de notre ami Jean-François Lasserre qui va sortir dans quelques semaines maintenant, intégralement consacré au bridge cantilever. Et puis notre histoire, en fait, c'est une histoire d'amitié, parce qu'on a des liens très forts avec Jean-Pierre, des liens d'amitié, des liens professionnels. Lui, c'est le cas pionnier avec Loïc, donc depuis 2006, et spécifiquement avec l'utilisation de la zircone. Et quant à moi, depuis 2009, donc 11 ans déjà, avec l'utilisation de l'IMAX, plus d'une centaine de bridges collés cantilever ont été réalisés dans ma pratique quotidienne et universitaire depuis cette date. Donc je vous donne rendez-vous pour la présentation qui durera environ 1 heure. On verra en détail toutes ces recettes de cuisine. Merci encore beaucoup Jean-Pierre. Merci à Ivoclar Vivadent pour me donner l'opportunité de m'exprimer dans ce grand congrès de l'IES 2020. Merci.
Merci beaucoup Gilles pour cette vraiment très intéressante introduction à ces bridge collés cantilever. Thank you very much Gilles Tirley. Now the next lecture will be presented by Dr. Ernesto Enrique Diaz-Guzman from Mexico. How to provide beautiful smiles. In his lecture entitled How to Align Patients' Expectations with Clinical Reality, he will share insights about his interesting flowable injection technique to achieve it. So now, it's your turn. Ernesto Enrique Diaz-Guzman, please go forward with your lecture.
Thank you for your kind introduction, Jean-Pierre et al. Hello, everybody. It's a pleasure for me being here. The topic we are going to discuss is how to align patient expectations with clinical reality. And it's difficult, the situations of the patient. They want to improve the smile, and there are many factors that could be the limitation to do aesthetics or to bring back the function. So we need to be predictable and explain it. So we need to perform a mock-up so the patient could see a preview of the final restoration. So in the first appointment, it's necessary to make a very well protocol from outside to inside. This aesthetic analysis will help us to make a design and to have a better communication with the interdisciplinary team. Having the WhatsApp will be the key to do any kind of the steps of the protocol. So we perform the mock-up, and if the patient likes the result, we can give the next step and to do it with flowable composite. So we have the initial situation, the mock-up, we can do the injectable technique, and taking pictures of the mock-up close-up and intraoral will help us to modify any kind of detail with proportion, color, or sealing. So in this video, we will see the workflow of the case. Was a big change, big expectations of the patient, developing 27 flowable restoration that he has from 2 years ago. Was a problem the bite, so I need to reprogram in a centric relation position. Having a WhatsApp will help me to use it like a surgery guide or even the provisional. Weeks later, I can start to work again with the vertical dimension and to see if both sides has symmetry. With the videos, we will feel the motion of the patient, different expressions. And if you put it in a big TV, when you are making the second appointment, trust me, they make huge expectations and they close the deal of the work. So it must to have a good definition, the WhatsApp, because it's a copy-paste technique that we use the silicone matrix to inject the flowable material. So you do bonding, you inject, you remove excess, so it can be one by one the restoration. And well, an image speaks more than 1,000 of words. This long-term restoration, you can use it before you put ceramics, and you can leave it 5-7 years. The documentation that goes from outside to inside starts from the face, then with lips, and then intraoral pictures, so we can do a better aesthetic analysis and we can match the horizontal and the vertical position that the patient must have. So we start to taking impressions, it could be analogic or digital, to have a positive model that could be from stone or a resin composite. So we see how is Stefania, she has wear, she has bruxisms. We need to start to work with the mock-up. So I sent to the technician all the information and the design so he can develop, and then I do the metrics with the bisacryl and we see the impact of the face. And we will be better if we can do the video. So, well, we need to have the equipment, we need a good source of light, but the video will speak more than 1,000 images. So we see the before and after was in the same appointment, the same dress, the same position of the camera. So we can see if maybe the proportion is too high, too short. If everything is okay, we take pictures so we can complete the documentation, and then we will do the flowable injection technique. So we see the pictures. There's some spots that we need to work with the color, so I will make a minimal prep. Then from the wax up, I will use the custom tray and I will do the silicone index, so we will see on the video how is the process. There will be available 1 hour of the lecture that I will explain step by step how it must to be all this process. So we need to put this in water and then we will dry it so it only be wet, and we can develop all the silicone transparent on the custom tray. We put a layer on buccal and palatal and we match, and we see that there are some mistakes when I'm making the silicone. So it's necessary to use a dentro pressure pot so you can remove the bubbles, have a better material with better stability dimension, compact, better sealing. So we see the final result, and we will need to modify a little bit. So remove excess material, leave it flat, make a drill on the incisal edge 1 millimeter of diameter. Then we will put the Teflon tape one side and another side, acid etch for 20 seconds, clean, rinse with water, leave it dry completely, and then we can put the adhesive for 10 seconds. We will put air so we can have a thin layer, and like your 10 seconds palatal, 10 seconds buccal, we put the silicone transparent and we put the tip of the flowable so we can inject the material, then polymerize 10 seconds palatal, 10 seconds buccal, and we see how the interface line disappears. That's because I make a bevel of 45 degrees before injecting. So we see the color looks a little bit dead. It's necessary to make a polish and a high luster. So I will explain the protocol. This is 4 steps that we need to do. The first step will be with the polishing disc, that we will make it very smooth. It's necessary to use water, so we will leave homogeneous the surface of the composite. After that, we will start to doing the polish, so it's necessary to use a silicone polisher. It could be the cup, the point, the flame, and we will make a little bit of pressure on the surface of the composite. We will make it in the full arch of the upper and the lower, and once it's done, we will use a diamond polishing paste. And start to using the goat hair wheel. This one has leather on the middle, so it will give a better polish and a better luster of the restoration. After we finish this step, we will do the last one, that will be to use a cotton buff, and this cotton buff will be impregnated with aluminum oxide that is used to make the high luster of the ceramics. We use one impregnate, then we will use a second one that will be clean. And if we want a better result, we can repeat the protocol completely. We will check the final pictures so you can see how is the final result, being very predictable and being a copy paste from the WhatsApp. So first, the polishing disc. After that, we can use the silicone polisher, and then we will use the straight triangle to use the goat hair with the diamond polishing paste, and then the cotton buff impregnate with the oxidized aluminum, and the second one clean, so we can leave the high luster of the restoration. The impact that we create with this restoration is very predictable. This case is my wife. She has 5 years with the restoration, and it's very important to keep a maintenance that will be to make a new polish and high luster, because we don't want to have stains on the restoration. So there's a process that maybe will take weeks or maybe will take months. It depends on the situation of the patient, but trust me, this kind of restoration is very predictable, and in any time you can make the switch to ceramics. I hope you like this presentation. I want to give thanks to Ivoclar, and I want to give thanks to everybody. Stay home, stay safe.
Thank you very much, Gilles. Thank you very much, Roberto. Thank you very much, Ernesto. We can now begin our panel discussion, and we'll begin with a general question about the concept of your treatment. And I begin with Gilles, for example. Gilles, at this moment, with this new technique of resin bonded cantilever bridge, is there any indication, is there still any indication for implant in the anterior area?
Yes, obviously, because implant is indicated, but probably with the evolution of the cantilever bridges, lesser indication in the anterior region, and especially in the case of agenesis of lateral missing tooth, and also after trauma, when we have a lack of bone and lack of tissue. And in this case, it's more difficult very often to place an implant. It's possible, obviously, but it's more predictable, probably. What I mean, it's more predictable. And also with the pursuit of the growth, and some authors like Berens in his book in 1988 wrote that growth as defined as continue all day long, all the life long, and very later in the life, more than 50 or 60 years old. And this point is really a problem, because we have differences about the cervical line between the natural tooth and between the ankylotic system. This is the implant, obviously, ankylotic system and the natural tooth. And when the smile line is higher, this is a problem for the visibility of this difference of the gingival levels. And also, when you decide to put an implant, and when we have a problem, it's more complicated after to make the reintervention, the clinical reintervention. But when we place a cantilever, for example, to replace, for example, a lateral incisors or a central incisor, it's more easier after, at the end of the restoration, to place another cantilever, or it's possible again to place at this moment an implant.
Thank you, Gilles. Roberto, according to your new medical concept of treatment, are you alone? What is the role of the dental hygienist in this modern restorative dentistry, and what will be needed in the future to help you?
Thank you, Jean-Pierre. It's a good question. For sure, nowadays the role of dental hygienist is completely different from the past, because we obviously need a well-trained, well-prepared professional figure. That means that we need a good step, because normally the dental hygienist is the first step in informing patient and also in diagnostic process. So it's very important that she is very well trained about dental photography in order to communicate not only with the patient but also with all the professional staff, and in order to communicate with the team all the problems that can be revealed by the diagnosis process. And last but not least, also to suggest therapies, because it's very frequent in all the office where I work that during the dental hygiene, the patient asks to dental hygienist, what could we do in this tooth or in this group of teeth? That means how to correct the color, but not only how to correct the shape. So it's very important that this professional, very important figure needs to be prepared in order to suggest the correct therapy from the beginning, in my opinion.
Thank you. Ernesto, according to your concept of direct technique of restoration, it seems easy, but is it really tolerant to handling?
Yeah, if you have a good protocol, it will be easier to go step by step. I cannot tell you that it's better to follow up. I don't know. You have to have all the materials in that moment, because it will be difficult if you don't have all the stuff.
Okay, thank you. We can speak about materials, and I begin with Gilles. What do you prefer? Lithium disilicate, IMAX, or zirconia for cantilever bridges? And what are the advantages and drawbacks of each one material?
Yes, a very good question, because it's not very simple to choose between the both materials. And in the case or when we have a very high brightness of other tooth, and you have to replace lateral incisors or central incisors, it's better to choose lithium disilicate for its better properties, and especially the brightness and translucency and also opalescency. But the difficulty is to choose and in first with the mechanical aspect and with the place we have between the mandibular incisors and the maxillar ones. And the mechanical point is very important, especially at the connection, and the connection between the wings, between the ceramic wings and the replace the prosthesis, the replace tooth, and in fact the nature of failures are totally different between both materials. In the situation we choose lithium disilicate, if you have a failure, it will be necessary a fracture. No debonding, but fracture. If you choose zirconia, the failure will be debonding, but not fracture. Perhaps tipping, perhaps, if you have pressed disilicate over the structure, the zirconia structure, but more often is the debonding. And for this reason, the choice is not very simple, and especially with the evolution of zirconia. But at the beginning of the story, in 11 years ago, I have to choose in first lithium disilicate for his optical properties. But now is not so evident, and probably the safe way is to choose zirconia more often than before, especially when the occlusion is not exactly at the base place, exactly precise, and conserve lithium disilicate for the clinical cases where you have very high brightness with some very subtle optical effects. But my point of view is not so simple than 10 years ago now, from my point of view. And
thank you, clear. Thank you very much, Gilles, it's very clear. Ernesto, for the injection technique, of course, you choose a composite resin. What is exactly your composite resin? And you don't like ceramic?
Yeah, I like ceramics. That is very useful, that you have high flexibility, that it's easy to fix it, and it's a composite. It's what you do day by day in general dentistry. So you tell me about which composite do I use. I prefer to check the color, because even if I use a low or a high field composite, you know, a low field composite will have more translucency, then a high field will be more opaque. So it depends what are the needs of the patient. If I only gonna change the shape, maybe I can use a low field on the anterior, but maybe if I'm gonna have stress on the posterior, I will use a high field. So it's difficult, because I have used different brands, but you know that there's a little bit change of each brand. So every patient, the best way to check it is to test the material before you do the bonding. You cannot check the ceramic in the same moment. You need to go step by step, and if you're going to change the color, you need to ask the technician. Here you only remove the flowable, and you can go A2, A1, bleach, and it mimetizes very well, because the color comes from the inside. So if you have less material, like in the cervical area, it will look orange or will look more natural. But I don't know what the patient wants. If they want a bubblegum smile, like all white, well, you need to do it. So maybe I will use an opaque material. So it depends about the color most, because now in these days, it's not the same flowable like 10 years ago. They are, and you see that they are making injectable flowables right now in these years.
Thank you, Roberto. In your first step of your medical concept in 3 steps. Your first step is care. When you choose to use chlorhexidine and when you choose to use fluoride.
Yes, it's a good question. It's a good topic. There is a lot of confusion in generally among clinicians, especially in the world also of dental hygienists, because it seems not to be clear which varnish is needed to use or not. Okay, the role of plaque, of erosion, obviously needs to be checked before during the diagnostic process. But it's very important also to detect how much is the quantity of bacteria that we have in the mouth of our patient. That is the first step and the first goal, because obviously chlorhexidine-based products are indicated in all the situations where we have high level of bacteria. That means that obviously there are a lot of products that combine also these 2 types of molecules, chlorhexidine plus fluoride, but it's very important to understand everything from the beginning. That means the control of hypersensitivity, the control of erosion, and also the control of high risk level patients. So normally I work with very trained dental hygienists, because they perfectly know all the protocol that I will explain in the full-length lecture, because it's very important to understand with the DMFT, for example, with the diagram, what is the level, the risk of the patient according to the age of the patient, according to some parameters. So the number of decay, the number of missing teeth, and all the parameters that we need to combine them according to the age of the patient. And it is very important from the starting point of view in any situation, in any therapy, from restorative, direct restorative, for bleaching, for general control, or for indirect procedures.
Thank you very much. I don't want to forget the patient, and I have a question about the communication with the patient. Ernesto, you document very extensively, including videos that show motion and expressions. Do you provide patients with these pictures and videos to take home?
Yeah, sure. Because that will help you in marketing, or they will show to the family, to the friends. So it's very useful. And you know, you're in the appointment and you forgot what you speak. And the video and the picture, you can see it one time and another time. So that's why I think it's better to the patient take all the information at home. There's the risk that maybe they will go with another dentist, but most of the times it's very useful.
Thank you. Gilles, before the treatment, do you share the planification of the treatment with an orthodontist? And
yes.
After the treatment, what do you say to your patient? Is he authorized to do everything, to bite everything?
Yes, the first element of your question, GP, is the communication with the orthodontist. Is a very important point, because I asked to check the patient about 6 months ago the end of the orthodontic timing, just to check 2 important points. The first one is I asked to the orthodontist to increase a little bit the overjet, and I asked to the orthodontist to increase a little bit the overbite. And according to the minimal invasive preparation, to place the ceramic wing on the palatal surface, and to have the minimal invasive preparation inside the enamel. And obviously, I check other points like harmony of the smile, the position, the space, the diameter space, according to the diameter of lateral incisor or central incisor, all the checkpoints conventionally, obviously, but especially the overjet and the overbite. And it's a very important point. And obviously, according the nature of occlusion, impossible to place the cantilever bonded bridges when we have a supra-occlusion, class 2, angles class 2. It's not a nice idea because the obliqual strength, the obliqual forces are very deleterious for all the restoration, and the risk to have a failure is very, very important. And the second point of your question, GP, is the recommendation to the patient. That's it?
Yes. Yes.
And
yes.
I tell to the patient, all is okay to eat, obviously, to have the normal life with the food and alimentation. But I ask the patient to not to bite off the sandwich, or to bite off in the nuts or in the olive stone, for example, because we don't forget that it's a structure, a prosthetic structure in cantilever, and it's very important to conceive the importance of bonding, but also the importance of the distance in cantilever. And for example, if a patient bites on olive stones, for example, or nuts, or very hard elements, the risk of fracture is important, and especially with the lithium disilicate. It's also a differences between the two materials, lithium disilicate and zirconia. But it's not only the alone point, the simple point. It's very important to conceive also the connection, the surface of connection. With lithium disilicate, we need to have a connection about minimum 12 square millimeters, and for the zirconia, we need to have 6 square millimeters. And it's also an element of the choice between the two materials. But for the patient, I tell it's okay, you have your life normal, but just you take care with the other elements.
Thank you very much. I have many questions from the participants about the technical part of your treatment. And Roberto, for example, do you use chairside bleaching or home bleaching, and which bleaching material you use?
Okay, it's a good question. I mostly do aesthetic and prosthetic dentist in general, so my history started 17 years ago with the dental bleaching procedures. So I have been studying these procedures in order to connect also to prosthetic procedures. During the years, I discovered by myself that the most predictable dental bleaching procedure is given by home bleaching procedures. So I normally use carbamide peroxide in 10% concentration or 16%. But there are also some nice tools, some nice products, quite some varnish with hydrogen peroxide that are good for maintenance, and that they are very easy, especially when I decide, for example, to solve a case with the 4 veneers in the upper arch, just an example for the 4 incisors. And I have to decide, according to the age of the patient and to the request of the patient, what I have to do in order to deal with a good success in all the other teeth that are not involved in prosthetic procedures. In these cases, most of time I decided to use dental bleaching procedures before the prosthetic procedures. It's very important for some patients and very easy to be maintained also at home, or also in office if you like, but at home is very easy with hydrogen peroxide varnish. And obviously the first step of the prosthetic procedure in the treatment plan is represented by these procedures. That is not only cosmetic at all, but it becomes the first step of the prosthetic treatment plan. So I have to preview the final color in order to decide, for example, the color of temporary restoration. And I have to decide what I have to do also in the prosthetic, in the teeth that need to be covered with prosthetic restorative treatments. So we need also a good dental technician and all the other topics, but it's a very important topic nowadays.
Thank you, Ernesto. How do you use the silicon matrix technique with a rubber dam, and how can you know for sure that the matrix is in the correct position?
So to use it with isolation, we can do different ways. It could be a split dam that we can put it to premolar, and well, you will have a relative isolation. But if you want a full isolation, you need to modify the silicon index, like if the way that is the mock-up. So you need to follow up the margin and the papillas, and you need to remove the silicon. And then to be sure that it will fit, you need to have palatal support and occlusal support. Because if you inject, we see cases on the lecture that is full mouth, and the full mouth is buccal and palatal or occlusal restoration. If you don't have intact tooth, you can never know if you're in the correct position. You can see with beyond the silicon matrix and see the margin, but to be sure, you need to have intact structure.
Thank you. Gilles, when you replace a lateral incisor, do you prefer to bond on the canine or on the central incisor?
Okay, in this case, I prefer to bond on the central, on the palatal side of the central. And what's the reasons? The reason are the orientation of the forces, because during the propulsion the forces are in the direction of the movement and not oblique vectors, but in the straight along the propulsion way. Because the difference when we put on the canine to replace, for example, a lateral incisor, we have forces in oblique direction, and we have the forces along the propulsion way on the palatal of the incisors, and we have an oblique vectors of the force on the palatal wings, bonded on the canine, and we have very important forces and shear bond strength just at the connection, and it's not a good idea. And as recommended by Professor Matthias Kern, it's also the best choice to choose, in this case, the central.
Thank you very much. I have some questions about the preparation. First, Roberto, please. In case of unbleachable situation, how do you manage to properly manage discolored abutments?
Yeah, this is a very good question, very wide question, because unbleachable situation.
Short answer.
Short answer, yes. I will try to do my best. Well, the unbleachable situation are very common and are a challenge both for clinician and dental technician. Nowadays, we can use different materials. We can use zirconia if we don't need adhesion, or we can use also lithium disilicate. Obviously, if we use lithium disilicate like IMAX, that is really amazing, we need to choose properly the right ingot opacity, because obviously we need to avoid the translucent one, but we can use the medium opacity or high opacity ingots. If we use this type of material, also the preparation becomes very important. We can use very thin veneer up to 1 millimeter and cover a good discoloration. Obviously, we need to check the cause of the discoloration. We need to check if there is another possibility that could be represented by internal bleaching, for example, and sometimes if this means to avoid a prosthetic procedure. But in case of all the unbleachable, there are a lot of materials that are really wonderful and amazing nowadays, and they can be used also with minimal invasive prosthetic procedure preparation.
Thank you very much. Ernesto, do you do a slide preparation before the injection technique, cleaning, sandblasting, or something else?
Most of the times I make available on the interface line, like in a class 4, I do available like a normal composite. And you also tell me that if, I forgot, you tell me if I make the preparation and
yes, what else? Sandblasting, for example.
Sandblasting, I always make the sandblasting to have a better bonding. If we don't have the sandblaster, we can use a polishing disc, but we need to remove the prismatic layer over there.
Okay, thank you. Yeah, and Gilles, for your preparation, what is the evolution of your preparation? You stay on enamel, you keep enamel intact, most as possible?
Yes, at the beginning of the cantilever story, 11, 12 years ago, we follow with you, GP, because you are the pioneer in the cantilever story. When I said in my lecture, 1 hour lecture, at the beginning of the story, we follow the Matthias Kahn recommendation with the very strict preparation, with the pinhole, with the preparation of all the palatal surface, and we make a box in the proximal area at the emplacement of the connection. And with the time, we need, from my point of view, lesser preparation, and it's better because no more aggression of the enamel. And actually, my preparation is very, very simple, and all in the enamel, in the proximal side, at the place of the connection, but also on the palatal surface, and no more pinhole to stabilize. But it's very important to understand that we need to have stabilization during the bonding time. And to replace the preparation, we use bonding keys manufactured or realized in the laboratory to place very exactly at the nice place the cantilever bridge. But with the time, lesser is better for the preparation, and essentially now in the enamel. And my friend Marco Gresnich studies in vitro studies, and Marco showed that only the connection on the proximal surface will be sufficient to resist to the forces for the cantilever. And actually, we are brainstorming with Marco, with UGP, and about the base profile, the base shape of the preparation to receive current cantilever, ceramic cantilever bonded bridges.
Thank you. We can ask some question about longevity of your treatment, Ernesto. What, in your experience, what is the longevity of this kind of restoration with injection technique, and do you have some scientific evidence?
We can leave the restoration 5 to 7 years. It's necessary to use a splint so the patient can use it when they have a stress. Well, there's no many documentation of the technique. That you can find a book of restoration with flowable veneers, restoring with flowable composite, and the doctor is Douglas Terry. He's the one that has cases more than 10 years. So he's the pioneer of the flowable injection.
Thank you. Roberto, what do you think about the longevity of bleaching?
Yeah, normally I always say that for internal bleaching, so for all the endodontic treatments, if we detect the cause, and it's very common to find the cause that could be, for example, pulp remaining or other problems that could be inside for a long time, so for 20 years, for example. And if we detect the cause and we are able to remove the cause and then we bleach the tooth, we are able to say that there is a good success and no recurrence yet. And this means that for internal bleaching, the concept is completely different. For vital situation, obviously the longevity is completely different because the color could change, not for all lifelong. But it's very important to understand that the technique and the material are very important. In my opinion and in my experience, if we use strong power material, the result will not stay for a long time. That means that home bleaching procedure with low concentration is better than power and power action. That is very cool, very modern, very required by patients according to fast food and everything that needs to be fast. But it's not, in my opinion, not our goal, because if you want to give success, it's better to offer the better for our patients.
Thank you. And Gilles, what is your average longevity of such cantilever bridge?
The longevity for all studies, clinical study, is very important, and survival is defined as a prosthesis that in situ at the time of the review, irrespective of its condition and recementation. But for the survival rate of the cantilever bonded bridge was about around 100% in most studies, as follows, for example, Sasse and Kern, and Sacker, and Saylor, and Amerle, Botello, and also for all the materials, not only ceramic, zirconia or lithium disilicate, but also for the metal. And because it's very important to understand that why the survival rate is high, because the freedom, the degree of freedom is totally different with fixed bonded bridges, and we have not the differential mobility, because we have one alone wing bonded on the palatal surface, and it's the great difference with the fixed bonded bridges. At this question, the survival rates for most studies is between 19% and 100%. And if I quote the survival study for the Professor Matthias Kern with the zirconia, at 15 years, the survival rate is about 95% at 5 years. And at 18 years, the survival rate is again at about around 80%. And it's very, very important and successfully therapeutic with a minimal invasive preparation of the tooth and the possibility, the amazing possibility to replace the cantilever by what? By another cantilever. It's possible, obviously, but also by an implant at this stage of the time.
Thank you very much. Unfortunately, it's time to conclude. So I have some questions to conclude. And I have many questions. And for example, for Ernesto, I have a technical question. How do you manage to take off the interdental flowable resin excess in your technique?
But in the cervix, in the margin, or?
In the margin. the participant imagine that you have some excess, and how do you manage to avoid this excess?
You need a dental pressure pod because that will give stability dimension to the matrix, to the silicone transparent. But also, what is the problem that you go to the margin when you are injecting? So while you put on the wax on the cervical, it's better 1 or 2 millimeters not to put wax over there. And even it's a flowable. Even if there's no wax, there's going to be a thin layer of flowable composite. So I prefer not to put 1 millimeter, 1.5 millimeters, and start to make a calibrate wax up, like the calibration of the veneer preps. And it's very useful. I see that that's one of the problems that people have when they are making the technique. But it's simple. Don't over contour the margin.
Thank you. Gilles, for you, a technical question to conclude. Which cement do you use to bond your cantilever bridge?
Now I use a pre-heated composite with 2 main materials, with the mark, the Majesty from Kurerai, and also ESTHETICS from Tokuyama. But it's possible and safe to use dimetacrylate polymer like Nexus, Violink, Choice, or other like that. But from my point of view, the use of pre-heated composites is very simple handling, very free handling, very easy to use to remove the excess of the composites when we bonding the cantilever bridges with the key, and also in terms of wear in the time, it's a very predictability to have a very nice resistance to wear and to
As the case for IMAX, Gilles, but for zirconia, you use the same protocol?
Yes, pre-heated composite for the lithium disilicates, obviously, and for the zirconia, I follow strictly the protocol, the Matthias Kern protocol, with MDP polymer and Panavia, but not the V5, but the F2.0, exactly like recommended by the Professor Kern, with a surface treatment of the wing with the coat-jets,
okay,
and saline primer after.
Thank you very much. Last question for my friend Roberto. A general question. What is the advice you want to tell a young practitioner who doesn't have this global medical view of the treatment, which I'd like very much? What would you say to a young practitioner?
Well, in my opinion, it's very important for young practitioners, also when you are in your history after the university, to start in the right way. So to follow the protocols for sure, but not to focus your attention only on the techniques, so the way of preparation or the way of cementation. It's important, obviously, it's strictly dependent to the final success in terms of aesthetic and function, but in my opinion, it's very important to start in the correct way from the first day. That means to use correct protocols, to have good teachers, to study, to follow, to read articles, and to stay foolish, because otherwise is very important, as Steve Jobs, to stay hungry, stay foolish. That was a good rule. Why? Because I think that for young people, you have to start with the correct diagnostic protocol, and then to follow all the steps in order to arrive to the function, to the aesthetics, and so to document, to use a professional equipment, to try to do your best every day because also dental photography is a part of our treatment plan. So I think that the day when I don't take my camera in my hands, I do my mistake, because something interesting there was to do and to check. So in my opinion, for young people and younger generation is to stay very hungry every day.
Thank you very much, Gilles. Thank you very much, Roberto, Ernesto. It was very nice discussion. It is the end of the fourth session live of the International Expert Symposium Ivoclar Vivadent. Any additional question will be answered and could be uploaded online in 24 hours. I remind you that you can have access to on-demand webinar for the long version of these presentations right after. Otherwise, we will meet again tomorrow. Be ready at the same time. Bye-bye, and thank you.
Thank you, Jean-Pierre.
Bye-bye.
Thank you.
Roberto. Thank you, Ernesto.
Thank you very much. Ciao, Gilles. Ciao, Ernesto. Ciao, Jean-Pierre.
Ciao, Gilles. Ciao, Jean-Pierre.
Thank you very much.
Thank you very much.